I'm a medical physicist. I work at OhioHealth, which is in Ohio, in the U.S., in the Midwest. Um, I went to University of Cincinnati, where I had training in health physics, and then moved into medical physics. Uh, but I mentioned the health physics because safety is kind of part of my educational underpinning, or so it's kind of my foundation. And that's what a lot of this is going to talk about. So I understand a lot of these things are going to be repetitive. You've already had several seminars on stereotactic, but I hope it's going to be a reinforcement of some things you already know, and maybe you pick up some things along the way. But I really like this quote from Socrates. You know, it's not just like you get a seminar about all the latest and greatest things and then you know everything. It's through repetition. At least that's how I learn. So obviously, technology is not the only piece of the quality assurance, quality control chain. Process management is also a large piece of it. So the departmental organization, the skills and knowledge of the workers, the structure of processes. So you essentially creating good processes creates a safe environment. So that's going to be the focus of this presentation. Obviously, quality assurance is embedded within, but I'm not here just to talk about Winston Lutz tests. Here to more talk about how you can create a safe culture. And a lot of this is shamelessly shared from the Netherlands. They wrote a really great report, and I've embedded it in other ideas, but a lot of it comes from this Netherlands process management and quality assurance document, and you can Google it, or you can email me and I'll send it to you. It's available for free. It's definitely more of a TG 100 or prospective risk analysis approach. So the assignment of responsibilities is kind of essential. It's one of the first and foremost things, like who does what and whose roles, and that's different all over the place, not just different countries, but different hospitals in the same city may have different roles and responsibilities, but it's really important that those are defined, and that's kind of a starting step. So these items in red are kind of statements from some guidelines, but my language isn't as definitive. I'm not here to be prescriptive, but more to be informative. I think it's really important that as professionals, you use your judgment. And there's a saying, and this is a paraphrase from a World War II flying ace, Douglas Bader. It's guidelines for the obedience of fools and the guidance of wise men. So don't follow things blindly. Know why you're doing what you do. So first and foremost, you really shouldn't do stereotactic unless you've got enough patients to be proficient at it. If you're doing one a year, it's not enough. Also, you should be following international standards to ensure that you're meeting quality and safety benchmarks. So stereotactic radiosurgery, it's high precision, high dose, high risk of harm. And it really would caution anyone to treat it as just a standard technique like any other, even though it may become routine or complex but routine. It's a procedure with minimal room for error and requires respect. One of my source documents, one that I rely on heavily, is this book by Lawrence Marks et al. From University of North Carolina. It's a great book. It's really not that expensive. There are electronic versions available out there. It's just really good, and I would encourage anyone in the field of radiation oncology to read it. It's filled with wisdom, and it's all about making radiation oncology a highly reliable we're turning radiation oncology healthcare into kind of a highly reliable organization, and that's got a definition that we'll kind of touch on later. So we're at a point where frames are used less and less, and frameless can achieve near equivalent accuracy to frame-based stereotactic when using IGRT. So, and also SBRT is dependent on IGRT. So the simulation and the pre-treatment patient imaging must be considered, and that those chains need to be focused on. These are two other books that I'd like to share that I believe are excellent and also available online, that have not just great information about the technical aspects, but also the different aspects for different body sites. So the challenge in stereotactic radiotherapy is the radiation of the target near or part of the organ of risk. In the brain, you're irradiating the organ of risk. So you've got a high dose gradient between the target and the surrounding normal tissue, and you need that maximum accuracy and alignment. So your precision is very important. Also, the highest dose gradient is typically near the critical organ. If you've got a lesion near the brainstem, you're going to have sharp fall off right next to the brainstem. So these are things that you need to be cognizant of. To get those high dose gradients, you have to allow for some inhomogeneity, and that's not always it's not always fully appreciated. But spiking the dose in the center is good. So the traditional quality metrics don't always apply in terms of heterogeneity. Just some basic definition. Maybe somebody else had shared this, but the stereotactic is rooted in Greek, stereos for three-dimensional or spatial, and tactos for ordered or range. So it's about three-dimensional arrangement or spatial orientation, and it's all about the geometry. Not all about, it's also about the dosimetry, but we'll get there. So as I mentioned, frameless for cranial radiosurgery is more and more common, and that's increases patient comfort. There are some compromises in terms of immobilization. Immobilization and fixation are two different things. So putting someone in a mask does not make them static, like fixing their skull to the table. And you need to be aware of what those uncertainties are. So determining those uncertainties for your particular system, whether you're using a frame or a frameless system, is important. And if you're going to use masks, it's recommended to use rigid masks. So those embedded with Kevlar or other reinforcing materials, such as carbon fiber, will provide a better and a more rigid support. And also bite blocks are important, but those are all clinical decisions that the physician will have to make, but the equipment that you use should be well characterized. So just to again, bring that into focus, that you shouldn't use a standard mask. You may do that, but you're going to need to evaluate the necessary margins to ensure accuracy and target delivery. And these are some studies that are showing the uncertainties that you can get with masks. And I've personally experienced shifts of 2 millimeters in brain lab clamshells. So it's very important that you know what that is, and be patient sometimes in terms of allowing the patient to settle, and understand why you have margins or don't have margins. but be consistent about it and have that rationale well understood by the treatment team. So those institutional margins, they should be agreed upon and relatively consistent. And this is just a kind of an example of the imaging where you would reposition the patient and verify. I strongly encourage the verification of patient positioning, just because masks and body bags, or people move. So I'm going to get into the quality assurance program. Another quote, this one's Aristotle. It's not an act, it's a habit. So we'll talk about that more. It's not just about installing equipment, but instilling values. So again, the focus of this presentation is the process management. So departmental management aspects, as well as the treatment technique process, which is important. But this needs to come from the leadership first. You need a strong leader who will help champion this process. And this is all in line with AAPM TG 100, where you're looking at the risks prospectively and determining where you should focus your efforts. So some of the reasons for this are the choices made by the department management influence in a positive or negative way the quality and safety of a new treatment technique introduced into clinical use. And retrospective analysis of published incidents have shown that this is where the failures occur. It doesn't occur, well, it can occur because of incorrect output factors, so there can be technical features, but the majority of failures are in processes. So that's why your quality assurance shouldn't just focus on the machine, but on the entire process chain. And obviously, technology changes fast. So talking about the latest way to QA a Vero Linac might not be so useful, but some of these things I think will be helpful a long time. So again, performance is only possible if you have the right processes in place. So it's more than just installing the equipment. It's embedding the values of quality and safety into your program. So a well-functioning organization, an efficient organization is a safe organization. So part of that is training, like you're doing right now, and I'm sure many of you have been doing throughout your careers, and it's what we all do. But that's developing that knowledge base and with practice is what really leads to a safe department. And most modern equipment fulfill many of the technical quality and safety aspects, especially some of the newer machines. They have beautiful automated quality assurance capabilities. I'm thinking of the TrueBeam's machine performance check, but there are other ones like the Electa's FlexMap Cal. Those things used to take a long time to do manually, but today we can adjust those rather quickly and efficiently. So here's kind of a 10,000 foot view. So we've got the quality assurance program, which envelopes the whole thing. The treatment is embedded in there. But before we get there, we've got prerequisites, and it's what you should have before you start a new program. That process chain is very similar, whether it's HDR or stereotactic or conventional treatments. The process chain is often very similar, but the prerequisites, the things that you need to determine to ensure that that process chain goes smoothly are going to be different. The equipment will be different as well. So we're going to spend a long time on the prerequisites. And another quote, well begun is half done. And that's why we'll spend a lot of time on the prerequisites of a good program. So, this is not a one and done. So it's not just before, but it's during the program. So it's not just before you start a program, but it's at regular intervals after a program has started. They have different, we have different quarterly meetings, sometimes mandated by ACR for the continuous quality improvement. That should be kind of embedded in the culture of your department, where you're reevaluating your quality assurance needs on a regular basis, because your program shouldn't just be static. It should be living and constantly improving. And a lot of the things, again, that I'm going to discuss, I feel like seem obvious, but if you review the literature of the errors, either they're not obvious or they require continual reinforcement. I think that's what it is. We have to stay vigilant and protect ourselves from complacency, because after we've done something for a while, it becomes routine. But that doesn't mean that it's any less risky. So a little bit about highly reliable organizations. These are some of their traits. One of the big ones is preoccupation with failure. So always concerned with where things can go wrong. So some of the other traits are, and I apologize, it looks like the format is a little bit, I did this on my desktop and now I'm on my laptop. Some of the other traits are that sensitive to operations, and that's what this is all about. The process management is operation. There's a reluctance to accept simple explanations for problems. Sometimes there's a statement of 5 whys. You keep asking, why did this happen? Well, why did that happen? And so on and so forth, because it's not always the obvious thing. So digging deep on errors and looking at near misses as opportunities, not for punitive, well, you did this wrong, but learning opportunities. Well, where in the process was this failure allowed to occur? So also a deference to expertise, understanding that we are part of a team sport. Healthcare is a team sport, and different players have different specialties and different strengths and skills. And then they're also resilient because they're constantly changing. So this graphic or this chart on the right is from that Mark's book, the Engineering Patient Safety and Radiation Oncology, and it's got kind of 2 tiers. So on the bottom you've got enhancing and initiating. So those are the 2 different states, with defects or without defects. So and up on the top of that, they have this conforming and expediting, and then also quick fixing. So it's very tempting to expedite things and to fix things quickly. And expediting is a particularly tempting thing to do. Everybody likes to feel like a hero, and if you can make things work quicker, it feels good. It's a short-term reward, but what it leads to is cutting corners over time, and we can talk about that a little bit more. But you should be relatively rigid in your processes. That doesn't mean that they can't change, but they shouldn't change on the fly with the patient on the table. And we'll continue to talk about that. So here are some of the aspects of the prerequisites. Obviously, the infrastructure, having a vault is important. Also, having well-trained people. You are an essential element. Having the technical support with service contracts, having the right patient population to ensure that you're going to maintain your knowledge and expertise. And all these items kind of we'll touch on. Again, they should be reevaluated on a regular basis to ensure that you're maintaining the same or you're growing the level of quality. So processes should be straightforward. An efficient process is a safe process. So, and I mentioned it before, you should not permit workarounds. They're like candy. I mean, they're good in the moment, but they're not good for you in the long term. So you should have all the time to validate the systems and subsystems. If you have if you have the opportunity, or if you're starting a new program, it's much better to get it right before you turn the key than after, than trying to fix it and trying to fix bad habits once they've started. So again, experienced personnel is key. All of you making the commitment to continuing education it's great, and it's kind of becoming the expectation, and it should be, because we should constantly be learning. I also want to mention that the processes, the rationale for the steps in the processes should also be well understood and documented. You want all participants to know why they're doing the different things. A person should never say we're doing this because we've always done it, or well, this is what's on the piece of paper. They should know why they're doing it, because if you have an understanding of why, then you have a stronger understanding of the value. So some other items: workload. It's really important to focus on the personnel and making sure that there's sufficient staff. Having people doing things after hours, while sometimes is not avoidable, those people shouldn't be also there at 6 a.m. Performing a stereotactic, and then there and after they got home from 11 doing QA. Just need to be very cognizant that the workload is reasonable to promote safe practices. Forming a team, whether it's the entire department that is small and so they're doing it all, or if you have a large department, having a dedicated stereotactic team that works together and is trained together and has learned the processes together is very valuable. So keeping that team stable is also very important. And again, knowledge. Each member of the team should know about all the different process steps, so that they can call out when either something wasn't done or when something doesn't look quite right. Again, it's a team sport. So just because the nurse's job isn't to check the mechanical isocenter of the machine, she should understand why you're doing that, and if that box isn't checked, she should feel comfortable in asking, did you perform the Winston Lutz prior to treatment delivery? So specific quality indicators should be added relative to conventional treatments. So increased tolerances are common, but one of the biggest thing that should be done on a periodic basis is an end-to-end test. So looking at the entire chain, and we'll spend some time on that, on why the end-to-end test. Also the Winston Lutz test, where you check the machine's isocenter, or the radiation isocenter relative to the mechanical isocenter. But the end-to-end test is particularly important because individual uncertainties are very difficult to correlate with the outcome. So it's much better to kind of get that system approach and to see the end result. You also want to make sure that your protocols are up to date and you have a good way for protocol management and control. So whether it's you've got them time stamped or you've got them labeled by time, so that everyone knows that they're following the latest. And risk management, which we'll talk about, is going to be looking at it prospectively and looking for where the checkpoints are and where they should be and what you should be doing. So those timeout procedures, those crucial timeout procedures. And you should be transparent about all that, and feel free to compare your processes with other departments and aim to improve your workflow. The sunlight is a good thing, and sharing your practices with others is the best way to learn and grow, because they'll learn from you and you'll learn from them. The end-to-end test, not just before starting the treatment, so not just during commissioning, but also on a regular basis. Annually is suggested. You can do it more often, but end-to-end tests are invaluable in giving you the overall uncertainty in your treatment delivery, and that's what quality assurance is all about, is minimizing that uncertainty, or at least bring it to an acceptable level. Also be open to external audits. In the U.S., I rely heavily on RTOG credentialing, so getting those phantoms and irradiating them and sending them back is invaluable, because I have a third party that's telling me that the system is working properly. Again, the quality assurance program is a living thing, so you should be reflecting as things go on. And I mentioned earlier about cutting corners. Something to be aware of is a phenomenon of normalization of deviance. So people grow accustomed to deviant behavior the more it occurs. When someone cuts a corner and nothing bad happens, and everyone sees that nothing bad happens, they become complacent, and so it just should not be allowed, because the first time might not be so bad, and the next time might not be so bad, but it's a slippery slope, and you may find yourselves well out of tolerance, and so cutting corners really should not be tolerated. And I don't say tolerated in terms of being punitive about it, but it should not be a value that's accepted. It should not be something that's accepted. So part of that living process, when something changes, repeat the analysis. So look at the whole thing again, and this is the Deming cycle: plan, do, check, act. And this is the method for continuous quality improvement. So you plan out what you're going to do, you do it, you look at the results, and then you act to improve them, and repeat the cycle, And Deming's an interesting fellow who's really written a lot about statistical process control, and I would recommend looking into him. And another thing at the bottom there about the outcome data, things change over time, our knowledge improves. I would strongly encourage looking at not just the wider literature, but your own outcome data in terms of what results you're getting with your patients, and analyzing that over a long term. And that's a big recommendation, but it's done a lot to improve things. So again, you need management's and administration's commitment to technical support, maintenance contracts. You need the physics team to have an established tolerance and action levels for their checks. IT is important, ensuring that you have unambiguous data transfer between your CT or your MR to your treatment planning system and to your treatment delivery device is essential. It's always nice if you can have a dedicated IT person, but that's for very large facilities. at least have someone who knows your systems and knows the importance of maintaining that network infrastructure for your department. Also, relationships with outside medical specialties in terms of whether it's the cardiothoracic surgeons who may help you identify a lesion on a CT, or a radiologist who might go over the MR. It's important to have those relationships and those lines of communication open. Another thing, or another suggestion, is to reach out to other departments and use. You can trade the quality assurance equipment or quality assurance phantoms to kind of increase your library and increase your ability to test your system. So again, going back to knowledge, the number of patients is essential to go from complex to routine, or a complex routine technique. It takes a minimum number of patients, and this is touched on later. That number is not defined. We're pretty sure it's not one a year. We're like 99% sure that that's the case. But we don't know if it's 10. We don't know if it's 20. I have some values, but it's very important that you're doing enough to maintain that level of competence. So that's that good practice. And if paper and phantom is not enough, that number of treatments is not known, but it is important to be aware of. Also, when implementing a new technique, make sure to reevaluate it and start from scratch again if you need to. Lung SBRT is not the same as spine SBRT. So those should be evaluated separately, and those processes should be formulated separately. You can use what you learn from developing the lung SBRT program and apply some of those to your spine SBRT program, but they're different animals, and they should be respected as such. So risk management is different. There are different priorities for the patient, and there are different priorities for the organization. Be clear about what you're focusing on when. Both are important, but again, different priorities exist for them. Now, risk analysis should be multidisciplinary. It should not just be the physicist examining the treatment chain, but it should be a multidisciplinary team. And I know that there are competing demands for time, but this is time well spent. A failure mode and effects analysis, FMEA, is a time-consuming process, and it can be initiated and maybe taken on by an individual, but it certainly should not end with an individual. And the more people, the larger the team, the more disciplines you can engage, the stronger it's going to be. And there is good literature out there that shows some of these analysis that you can build upon. Also, if an error does occur, it's important to look back and look for why. And again, it's not, don't look for that simple, well, it was this reason, or I wish I had a good one off the top of my tongue, but it wasn't just that the typo or the prescription was written wrong. Maybe it was that the way that the prescription window popped up on the computer screen made it easier for an individual to write it wrong, or whatever it was. There are several layers to an error, and it's important that you peel back as many as possible. So the APM-TG 100, this is kind of a new paradigm. It's not so new. It's a few years now, but this is a kind of a different paradigm in terms of quality assurance. It's not just doing QA as assigned through a task group report, but it's looking at your system and your processes and looking for those failure points and focusing on the points of failure, the possible points of failure that can cause the most potential harm. So ask why. So knowledge and experience is essential. Obviously, everyone has a minimum education. That the training and experience should be guaranteed. There should be an expectation of a minimum level. But the knowledge and skills needs to evolve over time. And with there are these four kind of processes or four ways of learning. So first, you don't know what you don't know. So you're unconscious and competent. You don't know what you don't know, and then you know that you don't know, and then if you focus, you can do it, and you know you can do it if you focus, and eventually you do it automatically. It becomes a habit. But it's important to be cognizant of where you may be at in that chain, and there's a saying about confidence is competence, but beware of the novice, because it's really good to be aware of what you don't know and seek it out to strengthen those areas. Different types of learning, they're passive in terms of studying the literature, reading, and attending seminars, and observing. But the observation is not worth as much as engagement. So the best way to acquire the knowledge is to practice it. Like I'm doing right now, I'm actively developing my skills by providing this presentation. So giving these presentations, it requires you to summarize what the good knowledge that you've gained and regurgitate it. And I here on the side, I've listed a few different reports that go over quality assurance and stereotactic treatments. And obviously the first one is dated. The bottom one is relatively recent. So, and all of these are helpful, and doing a journal club is a great way to learn and to practice what you know. So building and maintaining a good level of competence and routine. Team members have to practice patient treatment in a sufficient amount. And I've mentioned this several times. And these are just some general guidelines. We don't know what those numbers are, but 25 or more over a year is kind of a good expectation. Any less than 10 is questionable, and 10 to 25, that's they're saying is the kind of in between, make sure that you're maintaining that competence. And as mentioned it before, be careful in considering all stereotactic treatments as a single group of treatments. Specific lesions require specific competence, whether it's the lung or SBRT example, or something. You can't treat a trigeminal just like another, or like a brain met. It's definitely a different animal, and should be, the process change should be examined as such.
And Peter.
Yes.
I have a question sort of regarding that volume of patients.
Mm-hmm.
So INEN, Instituto Nacional de Enfermedades Neoplásicas in Lima, currently is kind of in the first 6 months of starting their SBRT program. And I think they've only done a few cases. And Juan, I don't know if you can hear me, but if that's right, you can let me know. And my question is, I don't know in your experience if you've seen this before, but a center is starting to do SBRT, but they're starting with a very low volume. And I think there's a lot of hesitance to start using it more because no one feels super confident. So how do you overcome that hurdle and begin feeling comfortable so that you can then start treating a higher volume of patients?
That's a difficult question. So in OhioHealth, they've been kind of going through the system and ensuring that each center is now doing Stereotactic, but it's taken time. And the way that we helped another center get that confidence was by cross-training people who had some experience. I don't know if that's an option, but having an experienced person, whether it's a vendor or a colleague, that's helpful for the first few treatments. But getting to that threshold, it just takes time. Going slow and being deliberate, being consciously competent is good. But it's also very important to know, limitations. I don't know that. I don't think that hesitancy is a bad thing. I think it's natural, and it's just something that will be overcome with time. I don't think that there's a royal road to get where you need to go. I mean, I think you've just got to take it slow and be aware of your limitations.
Okay, thank you, Peter.
Thank you, Ben. So, getting into equipment, obviously the medical devices are essential. So you also need to, if you're building a program, you need to look at what you need. And that might be just immobilization. When they started their Stereotactic lung program, I'm sure that they looked at the best way to immobilize the patients and settled upon something. There also are other items in terms of image registration and fusion, small field dosimetry, pre-treatment quality assurance. All of these items should be determined and decided upon prior to initiation. And again, that the fact that it's a living entity, the quality assurance or the program itself can evolve. And this is when you're starting a program, you may want to do pre-treatment quality assurance on every patient, regardless of whether it's heavily modulated or not, to get that confidence. So every patient you do a dry run on, maybe something that and then as you develop, as you reanalyze and you see, okay, well, we're not really having failures here. Again, you're cutting corners. You need to be cognizant of why you're doing what you're doing. But you may decide that process was there just until you achieved that level of confidence in your program. So what level of accuracy or dose delivery to the patient is required, and how can it be obtained? So this is where we're going to kind of we're leaning into the end-to-end, because in terms of error propagation, if you take the isocenter of your collimator and the couch and the gantry all separately, those are 3 different values. You actually need to convolve them or pull them together to determine what the true isocenter is. So the composite effect of uncertainties, whether it's your mechanical isocenter or your image registration or your dose calculation, teasing out those individual components and the different contributions is really difficult. So focusing on the total uncertainty is a good way to determine the level of precision you can provide to the patient. And that's all about the end-to-end test. So you're looking at the entire dosimetric and geometric uncertainty from start to finish. And it's really important that you determine ahead of time what your limits are going to be, and those should be supported by the literature and reasonable. But you need to settle on that. Is a millimeter your tolerance, or is your machine capable of giving you a millimeter? Is 2 millimeter your tolerance? And those are questions that need to be answered ahead of time. So end-to-end tests should not be, you shouldn't be running the test to determine, what that uncertainty is. You should set what that uncertainty is ahead of time and then work to achieve it. So, and there are a lot of different parts in the treatment process chain, and making sure the data transfer is unambiguous. I mentioned this before, is really important. Especially if you're doing cranial radiosurgery, you need to make sure that that MR is coming in with the correct orientation and able to register with your treatment CT properly. And then that contour should be able to be planned on and then exported to the treatment plan or treatment machine without a problem. And this is a recommendation, and it's not always possible. If you can get a single vendor unit, then that's they say this is the recommended way to go about it. And I've had good experience doing both Varian and Elekta. So it's not, there's not one choice, but it is good to go with one. That way you can ensure that all the data transfer happens smoothly, and you kind of have a person to turn to. Obviously, that's not always possible. So just ensuring that you have functional cooperation between the manufacturers and you have good communication is important. So I think this is a really important item. Do not handle medical equipment as a black box. And I hope this goes without saying. I mean, you should understand why you're doing what you're doing. Not just following a guideline blindly, but understanding why the tolerance is what it is, understanding what's achievable. And that takes study and it takes time. And it's taken me a long time to appreciate these things too. When you talk about the dosimetric uncertainty in the penumbra or the buildup, understanding what that uncertainty is, gives you an idea of what's achievable. And the more you understand why something works the way it does, the safer you're going to be able to use that instrument. So if a vendor won't provide you with information, ask around. It's out there, but knowing why is crucial. So also talked about a lot of the tools to measure the accuracy levels of equipment, like the Mechanical Ice Center in terms of star shots and Winston Lutz. Those things are well known, but new equipment may require new additional tests, and performing a risk analysis on possible points of failure is essential. So when you have a new piece of equipment, acceptance and commissioning are two different aspects, and you should be clear on what's what. So acceptance might be the beam profiles and the depth doses, the energies, and the commissioning might be ensuring that the clinical delivery with an end-to-end test is within a certain specification. You need to make sure that those requirements and those goals are clear prior to starting. So the process chain itself, the process chain is not that much different than conventional radiotherapy. And whether you're doing frameless or frame-based or stereotactic in a body bag or just in a vac bag, this process chain is relatively constant, but it should be evaluated for the different areas. You may do a lot of PET fusion for your lungs or MR for your brains. It's important to make sure that all the steps work properly. So it should be yield optimal quality and safety, and it should be obvious why each step is performed. If it's non-obvious, the reason should be understood. And balancing quality and safety against efficiency and cost effectiveness often provides an optimal result. It is important to balance competing interests, but in terms of cost effectiveness, you could have 10 people there, but you can't afford that many. So you have what you can afford, and making sure that they know what they need to do during the treatment. But the Plan, Do, Check, Act, the cycle is very helpful in terms of reviewing your process and ensuring that it's efficient. And again, an efficient process is a safe process. So moving on to the process control, different aspects of ensuring that process chain moves smoothly. You should describe on paper the different steps and sub-steps in each area. Again, an engineered solution, a good process with hard stops is going to be the safest. So you should secure the processes with management and facility. Again, the cycle, Plan, Do, Check, Act. And each process should also have an owner, whether it's a sim tech who owns the simulation process or component of the process, or you have a dosimetrist or a physicist who owns the image registration, fusion, and contouring and dose calculation. Analyzing the different processes. This is kind of a framework for how to do it. But there's a couple of things in here. So this kind of gives an outline of a process. There may be like a call and a response, but the devil is in the detail, and that's got two faces. So one is, don't lose yourself in the details. And I am a physicist, and I'm prone to doing so. But don't do it. You gotta take a step back and understand why each element is important. And on the other hand, you got to recognize the essential elements. So figure out where the weak points are. But we'll oftentimes chase 0.1%, but that might not be the most effective use of time or focus. So checklists are great tools in terms of process control, but that is not easy, and you've got to be aware of checklist fatigue. So they need to be developed thoughtfully, and there is a medical physics practice group or a practice guideline by the APM that helps with their development. But again, the devil is in the detail. But a check should be useful, sensitive, and specific. It shouldn't just be a check to check. There needs to be a very strong reason and rationale that everyone on the treatment team is aware of. So the main factors that influence quality and safety are the work processes and the culture in your department. So the values that are instilled. looking at the risk management in terms of, and risk analysis in terms of prospective risk analysis is essential, and you can find out where the effort is best placed. And a multidisciplinary group is the best way to perform the risk analysis. Those risk analysis should show any potential risks in the treatment, the workflow, the organization, and there are tools that help you rank severity and importance of them. So the process aspects of the process control, the outcome analysis mentioned before is essential. Tie it all back to what's truly important in terms of the patient outcome. You should be looking at control rates is excellent, but the use of different margins based on fixation or positional accuracy, it needs to be weighed against clinical outcome. So, and that's a clinical decision, but it should be transparent. So again, overall uncertainty in the process chain should be stated, what you desire to achieve, and then you should measure it. It's the department's responsibility to ensure that uncertainty is maintained. So end-to-end tests are essential, and they should be a regular part of your program. And it's also the Plan, Do, Check, Act, or Plan, Do, Study, Act. Continuous quality improvement cycle is important to ensure the growth of your program. So starting up the program, make sure the dose delivery is accurate, and that can be in regards to the mechanical isocenter with the Winston-Lutz test, but also dosimetric accuracy. And here I've got a graphic showing kind of the challenge of small field dosimetry. This target, or the source, which is the target in the head of the linac, is occluded by the leaves in the small field. So a lot of your small field is just penumbra. So choosing the right detector for measuring those output factors, and not just choosing the right detector, but also having good reference data to compare your values to are very important. There's a lot of pitfalls to small field dosimetry, and there are task groups, and there's a new IEAE report on small field dosimetry that talks a lot about these subtleties, and that's kind of essential to setting up your program, is making sure that you have also limits about how far or how small of a field you can deliver with your machine. And it's also, I think, a rule of thumb is a target no less than twice the size of your leaf. So if you've got 5 millimeter leaves, the target could be a centimeter. But again, that's kind of a clinical decision, but it shouldn't be made in a vacuum. It should be discussed, and there should be a risk analysis to figure out if you can achieve the desired accuracy. And if you're using different phantoms, does the phantom require quality control? Can the phantom just be used out of the box, or do you need to do tests on the phantom? Another thing that I like to stress is the DVH grid, your dose calculation grid. and your imaging grid are not the same. It's important to ensure that you've got sufficient resolution, and that resolution is constant over the target. There are different planing systems that change the resolution of the dose grid, and that dose grid also isn't always aligned with your imaging grid. So these are just subtleties that need to be studied, so that you know what you can achieve. And then testing and figuring out what you can achieve by measuring, and you should set that target before you perform the test. And if you don't get it the first time, try to figure out why, and that may mean going back to the drawing board. So the big pitfall is that getting lost in the details. So again, it's important to keep the overall goal in perspective, and that's the treatment outcome to the patient. So you want to make sure that the target is irradiated correctly, that it receives the right dose in the right place. So evaluating those links, those weak links, is very important. So when you're testing the treatment planning system, don't test it in isolation. It should be tested in the clinical treatment process. You can plan something and it can look great on paper, or it can look great on the computer screen, but that doesn't mean it's what's delivered. So that should be part of your treatment planning system commissioning, is ensuring that you can deliver what's shown. So I mentioned it before. If you have a third party that you can rely upon, it's encouraged to do so. Kind of open yourself up to transparency and allow other people to test your system. It removes bias, and we all suffer from bias. And it's important to try to remove that if possible. And in some cases, you can't do the end-to-end over the whole chain. You may have a phantom, an MR phantom that doesn't have a chamber, but you can still overlap that in terms of test the image fusion with your MR phantom, and then on over to a dosimetric phantom. Also be aware of MR distortion, and any kind of, and ensuring that your registration is accurate. In terms of patient-specific tests, this is a great way to get that confidence, is the pre-treatment verification. In Europe, there is a discussion of kind of class solutions. This has got two terms. You can have a generic plan that you run on generic cases. Also, you can have different levels of modulation with the MLCs that require different levels of quality assurance. If you have less modulation, there's less chance for error in delivery, so maybe that doesn't need to be map checked prior to delivery. This is just a different paradigm. You want to make sure that you're using your time wisely, and not just doing a test because it's always been done. But evaluating that and ensuring that that you are performing the right tests for the right patients is important. And doing that pre-treatment verification, especially when starting new treatments, is very helpful. And of course, should realize that doesn't have the patient motion, and that's always the biggest uncertainty. Well, I guess contouring uncertainty, but we're not going to go there because that one's a rabbit hole. But the patient motion is also not accounted for in a lot of these pre-verification checks. So in conclusion, high dose, high precision target positioning requires the highest level of accuracy and safety in patient treatments, because errors can be irreparable and severe, and in some cases they can be fatal. So we need to be wary. So being cautious is important. It's important to maintain vigilance. But the safe implementation, maintenance and improvement of the type of this technique requires awareness and vigilance and by management and the professional staff. Don't become complacent. Just repeat the cycle. Analyze why you're doing what you're doing, and is it appropriate? Or are there weak links that could be strengthened in better ways? And finding a way to hardwire in the stops that can prevent those errors is very important. So there, just the final questions. You know, why do we need to perform stereotactic treatments, or what do we need? And you need dedication from the entire organization. What about the equipment to be implemented? You preferably want to be performed with a single manufacturer. If not, that's okay, but make sure everything is communicating properly and well tested. In terms of quality and safety, your process system, the processes should be straightforward and with well-defined control points. An efficient process is a safe process. And what about your overall treatment quality control? It requires end-to-end tests and well-trained and experienced staff that are committed to lifelong learning.